main reason we're here, really, is to hear from those who've had to do this and actually really learn from that. And to take us through the first workshop will be Stefan. And I would just like to encourage you all, I know the moderators and speakers will do the same, but we really would like this to be quite open for discussion and debate. So anyone asking any question, there are no silly questions, and there's only constructive questions, but we can get a dialogue going, and maybe some have different experience in what they're saying and actually have come up with a brilliant way to do it, or they've had exactly the same, etc. We're really interested to hear everything. So, yeah.
I mean, I would like just to make a very short statement. The fact that we couldn't really find, that we had contradictory evidence about organizational economic outcome in renewing health is not a surprise, in the sense that it was intrinsic of the fact that it was a randomized controlled trial. United for Health is really working on that, and it could not exist without renewing health. So we needed to be sure that clinically there were no disadvantages in telemonitoring. So I think the two are logically related, and one is complementing the other one, but it's not a failure what we've seen in renewing health. That had to be expected.
If okay. I gave that impression, I do apologize.
No. You didn't, but I wanted just to be sure that there were no doubts about it. Okay.
Thank you, Jane, for the nice introduction. I was just a little bit afraid that you would now send everyone off, because these were also nearly the final words with referring to the YouTube channel. But now we are still here in real life, and let's go for the first workshop. So this is now about going a little bit to practice. It's even, we have, there's a nice new famous three letters. So we have the LSPs, the large scale pilots in renewing health. So let's take some LSD, which means large scale deployment. So, after these nice introductions, it's indeed now my role to transfer this discussion into lessons learned in real life. And let me start with one example from an interesting exercise I learned in Germany. So by the way, my name is Stefan Schuk. I'm working for ITL like Marc Lange. Headquartered in Brussels, but I myself, as you can hear, from Germany. So there's an interesting exercise where hospitals, healthcare providers, and industry come together every year to agree on some new developments, joint innovations that they would like to do over the upcoming year, and then they meet after this one year again with some milestones in between to see what is happening, and they are doing things happening sometimes within hospitals. But the one example, and in 1 year there was a very nice telemedicine example in this way of working together. And this one was the one that failed when we heard the report the year after. And listening for the reasons was that they couldn't find in Germany the suppliers to provide them in a larger scale with the sensors they needed to use with their telemedicine equipment. So I think that can be very disappointing. And so what Jana just said, going at larger scale is not always trivial. It can really make deployments fail. Another element I think we should keep in mind that we become, of course, Mark made this morning in the introduction the bridge to AAL. So we are living in people's home. So if we want to stay in the living room for a longer time, of course we have to provide equipment, devices, services which are somehow really can stay there, which people have not to hide. Sometimes you find that people are hiding the telemedicine equipment behind a curtain. Of course, they do not want to disclose that they are ill, but it may also be because it's not really convenient and not designed to their daily needs. So moving from pilots to large-scale deployment to permanent services, there are some challenges, of course. The more obvious ones are also having the right contracts, running the right type of procurement. There may also be some changes that normally you have SMEs partnering in the smaller pilots, but there may other industry partners coming in, maybe interested, if going to larger scale, and so on. So I'm not going to steal the presenters, their presentations, but I just wanted to alert you what would be the interesting elements. Let me come back to a few elements which we couldn't overhear, obviously, that could cause problems. One problem that came up in both presentations was mobile connectivity. So maybe other regions in this room, do you also have the same problem? Is it familiar to you? For instance, in Veneto?
Connectivity, but in the city and in the, I think in the most part of the Veneto, we are a good in mobile network. I'm surprised at the situation of Galles. I have to admit it. I am really surprised.
Okay. And in Norway? I'm not sorry. Who was?
Okay.
Yeah, our situation is more or less the same as Veneto, but we have also considered the solution of Wales of using landline because of costs in some cases. So we are considering both things.
In Norway as well, in northern Norway, this limits the inclusion of patients, that we don't have mobile all over the area, even around Tromsø, the city of Tromsø, not all over there. I mean, exactly in the city, but the municipality is broader. It is a broader area.
Okay, what puzzles me now as a mobile phone user, of course, myself, is of course, we all use now the Wi-Fi functionality in addition, so maybe one way to overcome this, at least in people's home, would of course be to enable Wi-Fi. Are you not, okay, that's indeed a question, why didn't you use Wi-Fi then? In Wales and in Slovenia.
This is a very interesting comment, because when I speak with my colleagues in Munich, the HRS people, I tell them that they should have connectivity to landlines. They laugh at me. So technologists do not understand that there are areas in Europe which are not covered by mobile networks. So a solution which is only mobile has weaknesses today. So we should really think about all technology, which sometimes is a lot more reliable and widespread.
Yeah. Yes, indeed. So,
yes, also in the rural areas of the Netherlands, we have the same problem with mobile phones, but also with broadband internet. So now in another AAL project, we are now using satellite internet. So it appears not to be that expensive.
yeah, no, it's coming to the consumer market in the meantime. Yes,
it is 35 euros.
Yeah.
Including the satellite dish.
I know we have it in Germany. That's a very common now. Since 3 years or so, it's not so longer so expensive. No, that's true.
35.
And I'm also a little bit puzzled by the fact, if I may say so as moderator, that you are, Drago, that you allow your patients to use the phone, obviously, for placing phone calls. Because what I have seen from, or at least there seems to be a tendency to give a separate device to the patient. So, is it how do you do? Are they allowed to use it for phone calls?
Well, not because the package we selected is just for data transfer, but they can serve the internet, and they can watch videos. But the interesting thing is that at the beginning we actually wanted to give this as a gift to the patients, that they get more than smartphone if they participate in the study. So this was actually mean to attract them, but we have stopped this further thinking, developing this idea.
That makes me. Oh, sorry.
Just to say that with our diabetes, we only give the patient a phone if they haven't got their own. We use their own mobile phone, and then we just pay for the text message. But that was one of the issues. If we had to provide a mobile phone in the health board, they only have connections with mobile technology on. You have to buy it in through them. You can't have pay-as-you-go phones. There's no policy on not having pay-as-you-go phones, and that's what we wanted to give the people, because we don't want, if they want to use a phone as a formal phone, then they've got to put the money on themselves. But they, so otherwise they just have the text messaging, and then so we had a bit of an issue about whether we could use pay-as-you-go phones, but we went ahead and bought them anyway. But so far, with our diabetes, I think we've given out 5 phones. Everyone else uses their own.
And that makes me thinking about one of the comments that I heard from South Norway, where not on mobile phone, but where on tablets, they made available tablets to the patient, but they made available a tablet which was specifically designed, where the software was specifically designed, so everything was locked beside the function of the tablet. So here we have exactly this is the same discussion. Are we providing, or are you providing to the patient devices from the market with all the necessary functionalities, but then this is introducing a level of complexity, a level of a lot of issues in terms of usage. While if you are designing or able to design from a software perspective the device, to customize the device, then you have a different environment. But of course, this is a decision to be made. Yeah.
Yes, in line of this discussion. I think it's a problem that many projects face. We want to test apps, and then we have the question, are we going to give another phone to the patient? And so the dilemma in the projects I'm involved is, will they actually want to have 2 phones? Are they going to carry around 2 phones all the time? But if we lock functionalities, then they need the extra one. So I would like to hear comment on that, if giving two phones is a possibility, and if it's feasible.
Okay, so that's indeed an interesting question, because who wants to carry 2 phones? But obviously it's something that you have to discuss. Jana, obviously you want to step in? Okay. No, actually, in the list it was Rachel now first.
Yeah, all I wanted to say was that we also did the same thing. We gave them tablets, which we specially designed, and only gave them a couple of because basically we were dealing with predominantly elderly patients, and but now what we're finding is that there is a kind of a demand on the part of the patients to let them have access to additional functionality. So maybe it's a process where you start simple and then add back functionality, because, so that at the beginning it's not so threatening and it's not so scary. And then once they get used to it.
I mean, probably the solution is simply who pays for that. In the sense, you can give a basic functionality as part of a service, but as in your case, if they spend 150 euros for doing other things, they have to pay for it. And there is another very interesting issue, the difference between iPhones and Android phones. iPhones, unfortunately, are very closed system. You cannot really play with that. So there is quite a lot of pressure to use iPhones too, but there you hit a barrier, because there is a very limited amount of things you can do to change it to what you want to do.
Okay.
Well, yeah, I think also the issue about, it's just phones and whether you need 2 and tablets and stuff, but when we are scaling, when we're really talking scale here for a service provider to actually deliver to thousands of people, you cannot afford to have to buy separate devices for everyone and install them. It's just not economically sustainable. So, I mean, you say, I mean, maybe if the scaling down part that you were talking about, you can reuse devices, etc., but you really have to think about providing too much to support them because you cannot scale economically. You don't have a sustainable solution in the end. I mean, one that would be affordable. And we've seen, Michelle, I mean, Scotland's got huge numbers, for instance, in United for Health. There's no way that many thousands of people could be handed a device and we'd have money to pay for that, even if it's just a project. But obviously we're trying to design it to be longer term, to be sustainable solutions. So, I mean, we're probably not there yet in the sense that we've got it all right, but we have to consider the cost of this as well, I think.
Yeah. Yes. Is it me first? Okay. I just want to say, I mean, the numbers for people having access to smartphones in Norway is now above 80%. And for the tablets, it's above 50%. So, and of course, these numbers have increased dramatically in the last years. And I suppose that's the situation in Europe as well. So, but maybe different numbers in the different countries. So, but this is something we take into consideration when we design projects, and now we can have that also as an inclusion criteria that people use their own devices.
I just wanted to add a bit more to Jana's point about Scotland. Because scaling up is a really strategic objective for Scotland, so that's a really big win for us. We've had some really interesting discussions with some suppliers already about having software that can be put onto patients' own devices, and that isn't ring-fenced to one supplier, but it's able to move around suppliers, and it's actually quite exciting what the possibilities could be. And I think to scale, that's an absolutely essential component, and we're taking that forward. So.
Oops, I just stopped my own phone. So I would like to make a short statement on this issue, because I think that the ultimate decision maker will be the patient. So patients don't want to have two devices. They don't want to have a device for diabetes, another device for COPD, because many of them have both diseases, and then their own personal use. So it is clear that the direction is just one device, and we have to deal somehow with the problem.
And I think what we are hearing is that, and learning, is going to be hugely relevant for in maybe 5 years' time, when many, many, many more of the people that have needs that we need to support them to live with will have their own devices. And we've got to shift our minds from thinking that we have a responsibility as healthcare providers to give people devices. And it's great to hear that most people are looking to, and I use the word loosely, but it's relevant, exploit what people are choosing to use as part of the lives that they are wishing to lead. We've got to exploit that as much as we can to give us a sustainability going forward.
Okay, thank you. Okay. Margo?
Well, we have patients that have combined illness, cardiac heart failure, and also diabetes. They got just one phone, not two. So all devices linked to one phone only.
I'd just like to make a comment about all the presentations, actually. I was involved with my colleagues from Tromsø in the early stages of this proposal, and when I was reading through it, I was saying, well, this is one of those huge projects, so many different trials, so many different conditions, it's just going to be a waste of time. And I had very few hopes on this, and it was a difficult process. But now I'm actually seeing commonalities, and the most interesting thing about this presentation is that the questions that are asked here are normally questions that we'd never reach in the normal projects where we start from scratch. So we are asking completely different questions. It's very interesting what is happening.
But it's a second project, so quite a lot comes from between the first one.
You know, I think that what becomes very clear as we have this discussion is that there are entry solutions and then there are longer term solutions, and we have to begin thinking about them both. Because, for example, if I look at the average population of our CHF population, they're above 75, 80. They don't have smartphones. They're scared to death of smartphones. And so I couldn't, I can't give them a smartphone. I have to give them something that's simple that they can use. But at the same time, we need to be able to begin developing our applications so that they will be easily adaptable, because the next generation will have smartphones and will be comfortable using smartphones, and they won't want to carry around two devices. So I think that we need to sort of see it on a kind of a continuum, a line continuum. But I think that you're absolutely right. You need to be thinking in the long term.
I think one of the things that we found really interesting that I forgot to mention in the presentation was that we thought with the COPD patients, by giving the tablet to them so that they could Skype in face-to-face through that system, is that they don't really want it. They're quite happy to do it through the text messaging system or just by answering the questions. If they can send you a message and get an answer, that's fine. They don't feel they need to see their clinician face-to-face through that system, whereas we felt as clinicians that they would want that. So that's quite interesting. That's come from us.
Yeah, I think it's not only a question of having 2 devices or 3 devices for each of the diseases, but also having different networks to provide different kind of services. For example, the solution that we have chosen in the Basque Country is using the telecare provider, how do you say it? Panic button, which is already established in the Basque Country, 30,000 social alarm, and it's through the social alarm provider that we are providing this telehealth system. So it's not, we have simplified everything, the panic button, the system and so on, with only one provider and one device, and using, in many cases, the landline, which solves a lot of problems. And it's quite sustainable, it's cheap, and we already have the infrastructure, we don't have to double service and so on and so forth. So we have to think about all those kind of solutions.
Okay, thank you. So currently I hear and see no other fingers raised. I think, no, that's what I'm just going to do. So I would have had 2 other issues to raise, but this one was interesting enough. Just what I could imagine, in addition to what you said, Jana, I think one could, in large scale, I think one could partner up with a phone provider. They could be interested to come in as a partner, and then a problem like having the data to pay for the data transfer may be solved. But what also came up was somehow if you use one phone, to restrict it, and not to be misunderstood, but you now get softwares to make your phone children safe and to have to limit its functionality. Of course, it can be this could be fine-tuned in another way. And I think also bring your own device is definitely also a trend in the mobile use of mobile phones and tablets in hospitals, for instance, where the staff brings their own devices. So why shouldn't we use it maybe for the patients in the telemedicine trials? In the large-scale deployments. Okay, thank you very much. I think it was for this lively discussion. We will have now a short coffee break. Let's try to reconvene in 10 to 12 minutes, I guess. Okay, thank you.